Okay, hi everyone. Good afternoon. My name is Shella Bozil. I am a licensed clinical social worker, and I'm one of the clinicians here at Collaborative Cancer Care. Welcome to another chat and chew. And today's topic I'll be speaking on is trauma and oncology. I just wanted to ask the chat, like, basically, what are your thoughts on diagnosis, treatment, oncology, and trauma? Um, we'll definitely get into different kinds of trauma, not really discussing the nitty-gritty of it, but just having some knowledge about, we call it big T trauma versus little T trauma. So today we're going to talk about how trauma impacts the mind, the body, and how these experiences can relate to the cancer journey. Trauma is not only about what happens to us physically, it also impacts our nervous system, our emotions, our relationships, our sense of safety, and even how we experience medical care and healing. For many individuals, a cancer diagnosis itself can feel traumatic. You got treatments, surgeries, uncertainty, changes in the body, fear of recurrence, and loss of control, which can activate the same survival responses we see in traumatic experiences. So today's conversation is about understanding those responses with compassion rather than judgment. So trauma can look different for different people. Some experiences that are traumatic are considered big T traumas. These are deeply disturbing, life-threatening events or disasters. And some examples are things like war, explosions, experiencing fires, hurricanes, floods, natural disasters, um, sexual assaults or violent assaults or violent assaults, severe medical emergencies, death of a loved one, death of a parent, or major accidents. These experiences overwhelm a person's sense of safety and survival. These are there are also what we call little T traumas. These may not be as life-threatening, but still impact people deeply and on an emotional level. So examples of little T trauma are criticism, maybe living in an environment where you're constantly being criticized, belittled, emotional abuse, bullying, rejection, feeling unseen or dismissed, disparaging remarks, loss of a pet, and repeated invalidation. So again, the difference between big T trauma and little T trauma. Big T trauma are very deeply disturbing, life-threatening events or disasters. Little T traumas are also deeply disturbing, but may not be life-threatening, but still very impactful on an emotional level. Little T traumas matter because repeated emotional pain can shape how safe or unsafe we feel in a relationship and in the world. In oncology care, both types of trauma can show up. For some individuals, the cancer diagnosis itself may feel like a big T trauma because it threatens life, safety, identity, and the future. For others, there may also be little T traumas throughout the treatment. So examples can be feeling dismissed by providers, losing independence, or your sense of identity, body image changes, social isolation, and difficult comments from others, whether they mean well or not, and also feeling emotionally unsupported. Trauma is subjective. What matters most is how overwhelming and powerless the experience feels to the individual. So, in other words, I can't tell somebody else if what they experienced is traumatic or not because I'm not in their body. Only the person experiencing the event can really say if it's traumatic or not. So now we'll talk about the nervous system and trauma response. When trauma occurs, the sympathetic nervous system automatically activates. This is the body's survival system, the fight, flight, freeze, or fawn system. The body prepares to protect itself from danger. Stress hormones like cortisol, adrenaline flood the body, heart rate increases, muscles tense, breathing changes. During trauma, people may experience panic, confusion, hypervigilance, emotional overwhelm, physical distress, physical or emotional numbness, and feelings of paralysis or powerlessness. Excuse me. Some individuals also experience dissociation. Dissociation is when a person feels disconnected from their emotions, body, thoughts, surroundings, or a sense of self. It can feel like zoning out. It can feel like being detached. It can feel like emotional numbness. It can also manifest as memory gaps or even feeling unreal or disconnected from the body, almost like you're dreaming, or even if like you're outside of your body watching yourself or watching things happen. Disassociation is not a weakness. It's actually a protective survival response. The brain or the psyche attempts to shield the person from overwhelming emotional or physical pain. So you can think of it as the brain saying, okay, what's happening now is way too overwhelming for us to process because we still have to live life. So we're just going to kind of go offline, let whatever happens happen, and then we'll come back online when it's done. People may describe feeling emotionally numb, disconnected from their body, or as though they are watching themselves from the outside. Trauma can leave the nervous system feeling stuck in survival mode long after the danger has passed. This may contribute to chronic anxiety, sleep problems, fatigue, irritability, difficulty relaxing, fear of recurrence, and feeling constantly on edge. This is why trauma-informed care is so important in oncology settings. So maybe in the chat, anybody, um, maybe write like an example of how a trauma can show itself um, in an oncology setting, like maybe during an appointment. What are some ways you think someone's trauma response is activating as they're either waiting for their appointment or even during their appointment or after their appointment? So next, I'm going to touch on attachment theory and relationships. Might seem like I'm kind of going in a different subject, but it connects. So to understand trauma more deeply, we also need to talk about attachment. Attachment refers to the emotional bonds we develop early in life with our caregivers. These early relationships shape how we experience safety, trust, emotional regulation, relationships, and self-worth. When we are born, the brain, especially the social and emotional parts of the brain, is still developing. Those neural connections grow through relationships and caregiving experiences. Attachment theory teaches us that the infant depends on its caregivers for survival. When caregivers are responsive and emotionally attuned, children learn I am safe, my needs matter, people can be trusted, I can regulate my emotions with support, and the world it's safe for the most part. Over time, these experiences shape our attachment styles. So there are four attachment styles. We'll start with secure attachment. So individuals with secure attachment often feel more comfortable with asking for support, trusting others, expressing their emotions, and regulating their stress. During cancer treatment, they may still struggle emotionally, but often feel more able to seek help and lean on relationships. Then we have insecure avoidant attachment. So individuals with avoidant attachment may have learned early on to suppress emotions or avoid depending on others. In oncology settings, they may minimize symptoms, avoid vulnerability, isolate emotionally, struggle asking for help, or appear emotionally detached. Next, we have insecure, anxious, or ambivalent attachment. Individuals with anxious attachment may fear abandonment or inconsistency. During treatment, they may experience heightened anxiety, reassurance seeking, fear of being alone, emotional overwhelm, sensitivity to changes in relationships or medical communication. And the last one is disorganized attachment style. So, disorganized attachment often develops in environments where caregivers were both a secure sense of comfort, but also a sense of fear. So, with disorganized attachment, this can create difficulty with trust, emotional regulation, safety, identity, and relationships. Medical trauma may feel especially activating for individuals with this attachment style. So, just kind of want to go back. I always like to explain secure attachment styles or attachment styles by just kind of explaining what the individual might have experienced as an infant and then toddlerhood. So going back to secure attachment. So where individuals are more comfortable with asking for support, trusting others, expressing emotions, regulating stress. So as an infant, they probably had caregivers that were very attuned, very responsive, um, when they cried, if they were hungry or uncomfortable, they had caregivers that would give them a bottle, rock them, play with them, but also their caregivers could look at them and tell what they need because they're attuned. So then that infant develops a sense of self, like I am somebody, if I cry, I'm going to get help. And so then they become a toddler and they start walking around. And because they kind of develop this sense that, oh, okay, I mean, the world is mostly safe because that's what I've experienced. So I can explore a room and my caregiver's right there. I see them. I can go across the room, play with something, and then come back, and then go back over there again and come back, and then they learn, and they develop. With an insecure avoidant attachment, this might look like an infant who had caregivers that weren't really present, maybe emotionally or physically. So when they cried, they did not get that responsive caregiver to pick them up, to feed them, change their diaper. If anything, they were avoided. So then when they became a toddler and they started walking around, um, they may be in a room where they can explore toys and their caregivers there, but they don't really feel safe enough to walk to the other side of the room and kind of play with toys or explore things. They also may not be that comfortable with going to their caregivers for that support, um, which kind of stunts their ability to develop and learn new things. And they probably see the world as kind of unsafe. And we have the anxious, insecure, anxious, ambivalent. So this might be an infant who had caregivers who are sometimes attuned and responsive, and then other times not attuned or responsive. I always use the example as maybe the caregivers might have had like significant mental health issues where sometimes they were there presently, other times they weren't. Or maybe they had substance abuse issues where sometimes they were sober, other times they weren't. So when the infant cries, they sometimes they would get what they need, and other times they didn't get what they need. So the world feels unsafe, and it's like, I don't know. I might cry, I might get what I need. Other times I might cry, sit here and cry and cry and cry, and I don't know if I matter or not. So then this infant develops into a toddler, starts walking around. Their caregivers in the room, and they may be afraid to even walk across the room to play with toys or um, just kind of explore. And they're just kind of very much attached to their caregiver, which again kind of stunts their ability to develop. And then the last one, disorganized attachment, is uh is a very sad one. So this is an infant who has a caregiver who's both the source of comfort and fear. So the world doesn't seem safe. And when they become a toddler and they're walking around, um, they may try to um, explore things, toys, or they may not. It's kind of like they don't know what they want to do. If their caregiver left the room and if the caregiver left the room, they would probably cry like, I want that comfort. But when they come back, it's like, I'm still crying because the same source of comfort is a source of fear. So like their caregivers could have been maybe abusive. Um, so all of these attachment styles really impact um, how people experience trauma. So, adverse childhood experiences is it's also known as ACE. So, in 1998, this guy, Vincent Felitti, conducted the Adverse Childhood Experience or ACE studies, which reveal strong connections between childhood trauma and long-term physical and mental health outcomes. So experiences such as abuse, neglect, household dysfunction, violence, addiction in the home, and chronic emotional stress were linked to increased risk factors for anxiety, depression, substance use, heart disease, chronic illness, and impaired stress regulation. The study helped demonstrate that trauma is not only psychological, but it affects the body as well. For oncology patients, earlier trauma histories can sometimes influence medical anxiety, treatment experiences, pain perception, trust in providers, emotional coping, and nervous system regulation. Understanding trauma allows providers and patients to respond with greater compassion rather than asking, what's wrong with me or what's wrong with them? We begin asking, what happened to me or what happened to them? So, in closing, I want to remind everyone that trauma responses are survival responses. The nervous system adapts to protect us. Sometimes those adaptations continue long after the danger has passed, but healing is possible through safety, support, connection, and self-awareness. For individuals impacted by cancer, trauma-informed care matters because medical experiences can affect not only the body, but also emotions, identity, relationships, and sense of safety. Healing is not about forcing ourselves to move on. Healing often begins by creating spaces where the nervous system can slowly feel safe enough to rest. Take slow breaths. Ask yourself, what helps me feel safe? What support do I need more of? And how can I offer myself compassion during difficult moments? So thank you for being present for today's discussion. Um, if you know anybody or if yourself you're struggling with just coping and especially with navigating cancer, reach out to someone, give us a call. We're here. And please drop any questions you have in the chat. I will be here to answer. All right, so I'm bringing everyone into the room again for any questions or concerns. Mhm.
Hello, all. It looks like Shella got booted, but thank you for joining us on today's session. And tomorrow we'll have our grief support group at 12. Thursday, we have oncologic expressions and yoga on Fridays. If you have any questions, feel free to give the office a call, and we'll see you next week.